The last session, we left it for left lower extremity arterial thrombectomy. And actually, yesterday we were talking about, so many tools that are now coming out on the venous side. Dr. Harth at one point said that there were 69 devices that were coming out on the venous side. I feel like same thing is happening on the arterial side. So let's see what's happening. We're going to start with Dr. Zach Rosol, and he's going to talk about pump-assisted thrombectomy. Thank you, Zach.
Thanks for the opportunity. I totally echo that. I mean, I was in awe listening to June's talk yesterday with all the PE devices coming out. It's like, how are we going to choose? And I think a lot of that type of technology will then translate probably into the arterial space potentially too. Okay, so we're going to talk about pump-assisted thrombectomy. I don't really have any relevant disclosures for this talk. Here's a 52-year-old gentleman. He's got a mechanical aortic valve that was done years ago. He's not the spitting image of compliant. He has very variable INR, which is likely due to some noncompliance. He was referred for significant claudication, Rutherford class 3. Here's his ABIs. You can see his meds and his baseline labs. So I want to run you through his initial intervention. Typical common femoral, not overtly calcified lesion, was treated, pre-dilated with a 7mm balloon. A bare metal stent was placed and optimized, and here you can see here's the final result. This resolved his claudication. He was sent home on Coumadin and clopidogrel for a plan for at least 90 days and then to finish with Coumadin after that. He came back a couple months later in a relatively acute fashion with rapid acute limb ischemia, numbness in a cold leg that accelerated over really just a span of a couple days, okay? He was brought back to the cath lab after his ABI was significantly reduced, and he only had monophasic Doppler signals, and here's his angiogram, okay? So rim catheter, you can see there's a large filling defect that is in that stent and also extends distal to that. So I've already got a wire in place, but I mean, how are you guys gonna approach this? I think it may be different from an endovascular perspective, but I'd also be curious to hear some of the surgeons as well. So what are the important factors we have to think about when we're trying to remove this large thrombus or defect here?
Dr. Ramanan, what do you think? What are your thoughts?
So generally, whenever someone has acute limb ischemia, I do some imaging. So I'm assuming you had a CT scan, so you knew what the anatomy was. Because especially when there's inflow disease like this, it's really important to have imaging because you won't have a femoral pulse. You don't know what your access is going to be to do a thrombectomy or whatever the procedure is going to be. So first thing, I do imaging. And then, heparinize, obviously. And then what I do depends on kind of the clinical picture. What you described was probably Rutherford 2A. And so, I think suction thrombectomy is perfectly reasonable.
Would you start with so you would use a suction thrombectomy. You wouldn't necessarily move to a cut down and a Fogarty with this. I know you're going to talk about surgical stuff later.
I think the only reason to consider a cut down is to not embolize distally.
Right.
So I've done that sometimes, and you can make a small cut down to not embolize into the profunda. Now, if you believe in the suction thrombectomy that you're not going to embolize, then okay. But in some cases, not every case, I've cut down so that I can clamp the common femoral so that I'm not fishing out thrombus later, which I've done.
So great point. So one thing is to make sure that you have a sense of how you're going to prevent distal embolization. But let me come back to you. Can you, because it's a good point, very good point you made in my opinion. How does the imaging going to change your approach? Meaning that, let's say you found that there was an embolization distally to the pop. Would that change, your treatment? Can you share how you use the imaging?
Yeah, so I think the imaging helps to decide what is going to be, so if we are going to do endovascular or open, in some aspects, depending on where the thrombus is. So if this was, say, a complete aortoiliac occlusion bilaterally all the way down to the groins, I might just start with cut downs. and then protect my profundus and my SFA so that things don't embolize, and then do open thrombectomy. That might be my approach rather than doing endovascular. And then it also tells you the level of occlusion. So it might be multi-level. In this case, you're lucky it's just this one level.
Right.
You might have more than one level thrombus.
I didn't show the CT scans, so we did know that. But yes, we knew that it was limited to the iliac system.
But it gives you the extent of your disease process. And then if we are going to do anything endo, it tells you what your access should be.
Yeah, I think this is a great point. I feel like sometimes, for non-vascular surgeons that are not very image, maybe friendly, let's use that word, we don't do enough CTs, especially in these settings. And then we get into the procedure and we get into a problem. I don't know, any comments from you?
So I have one question. How compliant is he? Because I think that will change the management of my approach too. Because
Tell me more about that.
what's that?
Tell me more about that. He's got acute limb ischemia, so how is it going to change your management of...
So number one, if we are doing a thrombectomy and so if he is compliant, then what is the pathology? Is he hyperthrombotic? If he is not compliant, then because if we aspirate this thrombus, if the hyperthrombosis is the problem, he's going to come back in the next 3 months. So then we may have to think about a surgical approach. But if he's non-compliant, and then I would do and reinforce compliance of the medication. But my approach would be an endovascular with a combination of Lysis too. So I will see how much thrombus I can aspirate, and if there is still residual thrombus, especially in the arterial system. Venous system, I'm a little bit more, it's okay to leave some thrombus. So in arterial, I want almost a full cleaning of the thrombus. So I will do Lysis too.
Interesting, great point. Yep, so let's move on. So thank you for making those points. That's exactly what I was hoping for. I think as an endovascular operator, and I always tell my patients, I don't do scalpels and sutures very well. I think the really important things for this, and you guys highlighted those, is plan so you don't make your problem worse. The last thing we want to do, and we unfortunately have all done it, is see that we have distal emboli and then have to chase things all the way down and down and down and down. So if you plan appropriately, you can hopefully try to mitigate some of those risks. So what we did, knowing that it was isolated to the iliac system, we felt a retrograde approach from the right common femoral was going to help protect us the most in that. So we started off with the 7 French Indigo Lightning catheter. This is the penumbra catheter, okay? So you initially bring this device up over a wire. You can advance it over a wire as well, and use the device with a wire, but really you get a slightly larger lumen gain when you use without the wire. Has a slight angulation to it, which allows you to articulate and steer, and it's very atraumatic. It has a computer system that senses when it engages with clot, and then when it does so, then it has a rapid washout of the catheter. It pulses 12 to 16 times a second to agitate that clot to try to engulf and break this into pieces, because clearly the thrombus we're dealing with here is larger than the bore of that catheter. So that's what we started with here. You can see us driving that without the wire in place, and we brought that all the way up and through. Had a lot of agitation, a lot of sensing. So you drive this catheter forward. When you hear it engage, it rapidly sequences. When it senses that it's open, it will stop. So we did that. We made multiple passes, and here you can see we didn't make a lot of headway, okay? And we have a 7 French sheath in now. So now what are our options?
So, Dr. Tsai, what do you think, and what are your thoughts? So they did suction thrombectomy. They're not getting much progress. But you were able to get through the stent. Is that
we were able to get all the way through the stent. Yeah, we wired through that and passed that very easily, but we can see it extends outside the stent as it did before, and it's still, it's all isolated to the common iliac. But we didn't have a lot in our aspiration container. We really haven't made a lot of progress here.
Now, I think one possibility is to use a bigger suction thrombectomy catheter, which I'm sure you tried. But remind me what the original stent was, bare metal?
Bare metal, yep.
So, in these cases, even if it looks like all the thrombus is gone, I always feel like there's some thrombus left. So almost always I reline these. For better or for worse. But in this case, I would try to get as much out. But I think you are probably headed towards relining this with a VBX. And because you're so close to the iliac bifurcation, you may be looking at kissing stents. Because I would try to stick the VBX out beyond your existing stent to make sure you trap the thrombus behind it.
So that's a great point. So you would maybe move to just trapping that thrombus right now rather
Well, I
than
would
trying
try
to
to
completely
suction it
remove
out more.
Yeah.
And, for me, I'm limited to whatever size penumbra I have. But there's, dozens of other options out there.
Can I respectfully disagree with that? So if you go to bilateral stents, now we don't know the pathology. Now we may be buying more problems putting bilateral stents. That is the only concern I have.
So I guess the question, we have two issues in hand, right? One is that we have a patient with ALI we need to treat. The other issue is that why did this happen? But you're suggesting that you think this is an embolization.
We think it was an embolization. He came in, his INR was subtherapeutic. Now, he didn't his echocardiogram did not show any significant valvular pathology. That doesn't tell you that it wasn't there before, but he didn't give us a heart failure history like he had significant aortic insufficiency or stenosis related to mechanical valve problems.
And on the CT and your IVUS, you did not notice any undersizing, any dissection at the tip of the stent,
No.
anything like that?
No, and if it was a dissection at the tip, this is 8 months after the initial stent implantation, you would think that would probably happen sooner. And no, on the IVUS, it appeared to be just organized thrombus throughout, and our stent apposition was very good. That's why we did the chromaflow to ensure there wasn't any areas of flow behind it where we would have malapposition. Yep. So we took, I'll show you what we did. Maybe. Where do I point this? Could you advance the slides for me, please? Thank you. Great. So as Dr. Tsai pointed out, there are larger catheters, okay? So what we optioned to do, and especially knowing that was large thrombus, is we placed a 12 French sheath and we brought in the 12 bolt, okay? So our presumption and why we failed was that was more organized thrombus than we presumed, and therefore the limitation of the 7 French catheter didn't allow us to engulf that. So we felt going bigger was gonna be better. Knowing it was organized, we were also worried about our distal embolization, so we knew if we upsized our sheath, we would help to protect, hopefully, against some of that distal embolization too. So this is the 12 French lightning catheter as well. Initially, this was part of the catheters that we used in the PE space before the Lightning 16 came out. 12 French, it has a little bit of an articulation angle. You can drive this over an 035 or an 014 wire if you feel like you want to maintain wire position, but it is also feasible with careful manipulation to use this without a wire as well. The mechanism in the computer system is still the same as it engages into clot. It switches into its rapid sequence mode to help agitate and engulf that clot. So here you can see we made a couple passes, one with an 035 wire in place. We brought that up and through into the stent, which I don't have pictured here. When we did advance without a wire, we did not want to distort the distal end of the stent, so we just brought that close, knowing that that clot was hanging outside. So after we did that, you can see here we've gotten rid of that thrombus, okay? We did repeat another IVUS. We did not see any significant thrombus, so given that some of the concern about potential medical noncompliance, we decided not to reline or put a second layer of stent here, even though it's a large vessel. If we would have, though, and we talked about it, definitely would have chosen the VBX for the heparinized stent if needed. But because we felt like we had good stent apposition and expansion already, we figured this was embolic. We felt less is more at this point in time. So we did pre-close this, so we were able to remove that and had a nice closure device afterwards, and this resolved the symptoms.
Very nice case. Can I ask you a question,
Yes.
maybe quickly from the panel, from a standpoint of the safety of advancing these penumbra devices through the stents? First, is there any concern? It's 8 months old stent. So should there be any concern about the stent getting deformed or anything like that?
No, I don't think so. As long as you fluoro the whole time and you watch it go up the stent, and sometimes what I'll do is I'll even put it up through the stent on a wire, and then on the way back,
Right.
I'll take the wire out, and on the way back, you can rotate it and bring it down. And especially the 12 French has like that deflecting tip, so you can actually rotate it and actually oppose it to the stent as you rotate it. But you have to be careful because you can move the stent, but it's possible to do
I
safely.
like that trick, the trick of putting it up the aorta.
That's
Yeah.
nice. Yeah, we initially went directly retrograde just because we knew that was hanging distal. We didn't want to push it up further. We were trying to pull it down into the catheter. But yes, that's a very great point that you can bring it back. And because this has such great suction power and that articulation, that you can move backwards through that thrombus. Yeah.
If it was a fresh stent, I would be more hesitant to do those kind of maneuvers. And in that case, I would probably just reline it.
That's all I have. Any other questions?
Thank you
or
very
comments?
much. We really appreciate you, and that was a great case and a great demonstration of the suction pump-assisted thrombectomy. The next presentation is Dr. Tarek Hammad, how to address acute and subacute ALI.
I'm just going to actually stay here. I was told last 2 days I put my back to the audience, so I'm going to stay here if it's okay. Great. This is better. Okay, so I'm going to present a case for acute limb, actually. No disclosures. Okay, so a 66-year-old man, smoker, came to one of our regional hospitals, which is an hour away, mid-June with acute onset left leg pain for 6 hours. He has intact sensory and motor function exam, no distal pulses, no left DP or PT, and his leg was mottled and cold. They put him in heparin drip. They called CMC, which is main camps for us. One of my faster surgery colleagues was on call, and that time he got called probably was around 1 a.m., but he was scrubbed in a case, and he had 2 more trauma cases coming with vessel injury, so he called me. I was on call for the endovascular team, and he asked if I can help. So we said, let's traumatize the patient, we'll take him to the cath lab, we'll take a look. So pertinent history, he had history of PTFE bypass, fem palpity on the left side. This was 5 years ago. And he's, of course, a smoker, and factor V Leiden heterozygous mutation with prior DVTP and Eliquis prophylactic dose. One thing to mention, he actually was seen one of the vascular surgery clinic 2 months before for short distance claudication of that leg. They ordered tests, they told him to follow up, but he never showed up. So he didn't get the test and he never showed up. So not the best patient. So this is his, as you know, this is, Rutherford class, you can call it 1 to 2A, so you have time to get imaging like CTA, which would be very helpful to the, panel points from last case. And I'm going to let it play one more time, but basically the iliac, here we're already at the, you can see the bypass, yes, the PTFE bypass occluded, there's POP is occluded. I'm sorry, this is not bone-gated, so you may see that there might be some tibial, but this is more calcium. The bone-gated, there may be, intermittent reconstruction peroneal, but nothing to the foot. But let's see the inflow. Let's have it play back one more time. So the aorta, iliac on the left side looks okay. The CFA coming here, you see there's some disease, probably thrombus, and the PTFE is occluded, native SFA is occluded. Okay, so we took him to the cath lab. This is already the time he got transferred. I mean, I was there retired for waiting for patient to come. I mean, this is sometimes happens, but time we start probably was around 3 a.m. Morning of the Monday 16th. So we went up and over from the right side. And as you see in the first panel, the iliac looks okay. The CFA can tell there's something going on. And in the second and third panel, you can see there's at least moderate center of the CFA and possibly thrombus there. And you don't see you see the knobs for the, I'm sorry. Go back. You see the knob for the, can you play these, if you don't mind, first and second panel? Good. Yeah, third panel, you see the second panel, you see knob for the SFA and the PTFE bypass, both occluded. And profunda looks okay on the last panel on the right.
So let's see, Tarek, what the panel thinks about this. So this guy is a
It shows the next
There's one more image?
One more just baseline image. So, here down, you see the profunda collaterals. There's no, you don't see the bypass at all. No popliteal, no tibials in the second panel. In the foot, maybe if you look very carefully, let me see, this is the, maybe here there's a tiny signal peroneal, maybe. Can you play the last panel, if you don't mind? Yeah, you can see tiny peroneal maybe comes back, but definitely there's nothing, maybe here. I'm sorry, it's a little bit so hard, but maybe, but there's nothing.
Limited flow coming down to the calf
nothing
and to
to the
the
foot.
foot.
Absolutely.
Very limited flow. Okay, so let me start with Dr. Tsai. So here's my question. Do you think the issue is that the bypass graft went acutely down? Do you think the issue is a combination of what's happening in the groin and the bypass? Or do you think that, like, how are you going to figure this out? That, you know, what's the issue here right now?
So, first question, did he have a common femoral endarterectomy before? Because the common femoral looks odd. Okay.
Not that was reported, definitely.
Okay.
You know, his
And then,
records,
second, their CTA was from vascular clinic.
no.
It was upon arrival.
He was seen 2 months ago.
Okay.
Tests were ordered, but he never followed up, never got any of the tests done. This CTA was from the time presentation.
So hard to tell whether his acute limb ischemia is from what's going on. I would think that it's from the occluded bypass, but he has a pretty significant profunda stenosis too.
He has
I
at
think
least moderate ostial profunda, I agree.
that is making him very ischemic, I think. I mean, I think it would probably be worthwhile trying to reopen the bypass, but you have to address the profunda stenosis also.
What do you think, Dr. Bashir? You know, what would you do in this situation? Because, you know, I think like there may be 2-3 things going on. So what are your thoughts?
You know, this kind of, I have done a few cases like this. I think the problem might be in the anastomotic side. And we don't, you know, unless you prove that with a recent ultrasound. So distal anastomotic, that is, and this thrombus might have extended to the profunda too. That's why there's no pristine flow and we cannot see any collaterals. One thing I would do is I would look at the pedal vessels with ultrasound. Can I get a pedal access to in this case? Just for 2 reasons. Can I do an imaging from pedal, number 1. Number 2, it can act as an aspiration, distal embolic protection too.
Right. What do you think?
I was just going to ask what
Do you have a mic here?
What was his exam like as far as pulses in his neuro
No
exam?
pulses. Yeah,
What about a neuro exam?
no left DP, no PT pulses, leg is mottled, cold. Definitely acute limb presentation, 6-hour onset of pain, but
still had
intact
sensation.
motor,
Okay.
He could move his toes, though.
Yeah,
and
intact motor
function
sensation,
intact.
definitely.
Because I'm looking at this as someone who doesn't do scalpels and sutures well, but this is a setup for someone having potentially compartment syndrome and having a really bad outcome based on how long this is going on in his exam.
6 hours.
Yeah.
So the problem here is inflow, of course, but he has no outflow. So I would lyse him so I can see if I can recruit outflow. If he has no tibial outflow at all after lysis, I mean, there is not much to do here, except maybe do a femoral endarterectomy and a profundoplasty and hope that helps him. But we have to recruit outflow. Without outflow, you cannot save this leg.
Yeah, I think, you know, I mean, if, the way I'm looking at this case is like, you know, is the issue common femoral profunda, and the PTFE is more of a chronic issue. That's why he came in 2 months ago with some claudication. So, I mean, the case can become a 5-hour case versus maybe an hour case. So, which I don't know yet, you know, to be honest. You know, I don't know if this is just a common femoral profunda issue that if I deal with, at least I deal with the acute setting, he still will have maybe claudication, you know, he won't, maybe I can deal with the rest pain and the acute issue. And then the PTFE is more of a chronic problem. I don't know if the PTFE and the groin and the profunda, all of this is new. And there may be some staging to it, meaning that PTFE went out a couple of months ago, he came in with claudication, and now he has this other stuff on top of it, which is making him very ischemic.
Great point.
But I think, you know, if you have an acutely occluded bypass, oftentimes you can wire it.
Yeah.
You know, the thrombus is pretty soft. It's like not organized yet. So I think I would try to wire it and try to see if you can shoot an outflow, because it can be very hard, especially with the profunda stenosis, to see any reconstitution of anything down, you know. As it looks now, it looks like he has no outflow, which is a big problem. But if you were going to lyse him, I think the best way to lyse him would be to lyse him into the bypass, if you could. You know, totally unclear if that's possible.
So anybody would have done native SFA here?
Excuse me?
Native SFA.
No, yeah. So I have one comment. If I'm, as Dr. Tsai said, you know, if it is acutely occluded bypass graft, it's relatively easy to get into. But I always, before putting the Lysis catheter, I always balloon the distal end and proximal end with a smaller balloon, like 5 balloon, and take it up to 4 or 6. Because I have seen cases, if you don't do the balloon, the distal stenosis there, the column will still stand with the Lysis.
And the TP would not circulate, so you have to make sure you have some sort of flow.
I mean, it does look on the CT scan like the occlusion is acute for the bypass.
Yeah, I mean, the occlusion.
Like thrombus and not
The presentation,
chronic.
everything. I think the stenosis profunda is probably moderate chronic, but the CFA thrombotic, and I think the PTFE bypass, at least my thought process, that was thrombotic, But definitely the moderate, already existed profunda stenosis didn't help, made his presentation way worse, And absolutely correct, there is no outflow whatsoever to the foot, like there is no foot to the foot. Okay, so next, you can see the thrombus actually more clear here, so I opted to do, maybe I've done wrong, maybe I should have gone with thrombectomy up front, maybe bigger device. I use this RX6 French penumbra, but before I ballooned, coronary mentality, I like to balloon just to get the outflow, inflow, just to see how much the burden of thrombus, and then do penumbra. And then I ballooned at the penumbra, and this is actually 2 hours. I'm not showing you all the images, but there have been a lot of, taking, injecting contrast, taking X-ray pictures in between, and doing more penumbra, more balloon. And next slide, I'm going to show you the end results.
I presume when you got through, one of the first things you did was take a picture of your outflow to assess that?
There's
just a gentle image with the microcatheter?
Yeah.
And you were obviously reassured at that point that you had some outflow?
No, I didn't. That's what I'm going to show in the slides now. So but definitely have done a lot of trans penumbra. We have done a lot of balloon angioplasty, and this is the results. So you see in the right side panel, there's some flow now to this is probably around now 5:30 in the morning. There's some flow to the bypass, definitely better. The outflow is through collaterals. There's still no poplite, no tibials, but you can see the tibials better. And if you look at the last panel in the foot, actually you see the plantar. So now at least you establish flow to the foot. Right. Anything wrong with these images, especially panel 1?
Dr. Ramanan, what do you think?
Profunda thrombus.
Honestly, I can't see outflow in the foot, but from these images, but I'm assuming there was something based on what you can see.
There's a profunda that has a thrombus now. So if you look at the first panel, so I embolize, getting my equipment up and
I see.
Through the CFA, there's a thrombus now to the profunda embolized.
So two issues going on, right? Two issues going on. One is that you have level of embolization to the profunda. The second issue is that you don't have a great outflow, meaning that you have some flow, but this is not going to last very long.
True.
Would you agree,
True.
Dr. Tsai? That to me, I think he made good progress. He's been able to clean, the bypass. There's level of embolization. We don't have outflow, and we have a little bit of embolization to the profunda. Anybody disagrees that this is the situation? Okay. So
yeah, at least I was comfortable because as you saw, and the first injection were full of contrast, 10 cc, and there is whatsoever no flow to the foot. So at least now we have a plantar. Okay, so this honestly reassured me. So for me, resolution was actually now not to mess with the profunda, because you can always make it worse. So if somebody suggested let's go after the profunda, I said no, I'm not going to touch it because I can turn it from having some flow to no flow at all, and now I'll be in big trouble. So what I decided to do at this time is to put a Lysis catheter. So I put an ECOS 50 centimeter, going from the inflow, which is a CFA in this case, and hoping that this will also drip into the profunda and take care of the profunda thrombus. And I made sure that enough length, 50 centimeter dripping length, to reach the outflow where the poplite it's not a poplite, but at least there are good collaterals. I mean, the outflow is not the best, but there's some outflow. And this would allow the TPA to circulate and hopefully take care of the clot. So this patient was sent to the ICU. I communicate to the next operator next day, which is Dr. Lee, because as you know, we come on Monday downtown, she's Tuesday downtown, so I spoke to her, and she said she'll do the relook tomorrow, and she'll take care of it. So this was my plan. Patient went to the CICU. Patient continued to have pain. Actually, pain, in fact, is severe. I got very pressure from the CICU team to take the patient back to the cath lab. This case was done around 7 a.m. I started my day because I had cases myself. I think I left 8 p.m. that day. And anyhow, every 1 hour I get a call from the CICU team, the pain is worse, can you please take him back to the cath lab? But the patient, we confirmed before he left the cath lab, I said, so he had a plantar. He had actually a PT pulse now. Monophasic, very weak, but he had a monophasic signal that he didn't have. And we made sure, actually, the vascular surgery team was already following because they were aware of the case, that's the one they referred, so they continued to follow up the patient for perfusion injury, compartment syndrome, etc. So I said, as long as he has a PT signal, I'm not going to take him back. We're going to have to be patient here. We're going to have to give the TPA time to work, and I'm not going to take him back. So next morning, I was not here, but actually the fellow examining the patient told me, guess what? He has now DP signal. So there's a PT and DP signal. And Dr. Lee took him to the cath lab next day. CFA still has some disease, looks better. The flow in the bypass way better. You see, she's a second balance. She's injecting selectively in the profunda. There's no clot on profunda. Thank God we got lucky. And despite injecting selectively in the profunda, you can see the flow in the bypass is very robust. The outflow, you can see the pop now, which you didn't see before. Peroneal, there's some severe disease, TPT peroneal. Peroneal, interrupted CT, interrupted distally a little bit. But definitely you can see even the plantar flow better, and you can see the hint of the DP, which explains why he has now DP and PT pulses on exam. So she did more work to ensure that we have longer patency of the bypass by getting more outflows for this patient. So actually was done a lot of work between atrex and thrombectomy using different devices, Angioplasty, and she was able to give him very nice 2 outflow vessels, peroneal and AT. And this is the last image. So patient, my key learning for, any comments before any comments?
Well, because of time, go ahead.
Yeah, so key learning for me, I don't know. I mean, honestly, if I knew this patient bypass was at our institution, the SFA was not ligated, myself probably I would have considered SFA even. I would give it a try at least, but the wire flew through the, like you all suggested, if this was acute, the wire flew through the bypass. And, upfront thrombectomy, I don't know, maybe it should have been first tried before PTA. Consider protecting the PFA, but I think if you don't do and you get a clot, don't fall in the trap of chasing it. If there is some flow, you can always make it worse. And Lysis can be very helpful sometimes. So just give it time to work and don't overreact. Unless there's a change in exam. So if all the data makes sense, just take your time, make sense of the data before you make any reactive move.
Wonderful, Dr. Hammad. I think that was a great case. And the one thing I would say, the lesson is that in these cases, the combination of mechanical and pharmacologic is a very good combination. Because you said it earlier, TPA works by conversion, right? Tissue plasminogen activator. So if you don't have flow, it's not going to work. And by doing a little bit of ballooning, a little bit of a mechanical thrombectomy that you did with Penumbra, I think you opened some channel, and then you did the right thing of not going after it and cause more problems. Did the Lysis, great work. Thank you so much.
No, thank you so much. And thank you. I'm also planning to bring him, to get ultrasound, the CFA, if needs ever endarterectomy to address the inflow, just in case for the future.
Absolutely. Thank you so much. That's wonderful. Thank you. Okay, the next presentation is actually going to be a continuation, I guess, of this one. It's a pharmacomechanical Lysis with Dr. Peter Monteleone. Thank you, Peter.
Yeah, that's a pretty darn good segue right there.
Yeah, that was a good transition. I think you guys planned this.
All right, thank you guys all so much for having me. Thank you, Dr. Shishehbor, Dr. Banerjee, for bringing such an incredible conference here to Central Texas. I'm an interventional cardiologist here in Austin. We're going to talk about a case that took place about 12 blocks north of here, and I'll invite everyone to participate in my post-traumatic stress from this case. So these are my disclosures. Importantly, I've had the chance to work with a lot of these companies that have really revolutionized what thrombectomy does and what thrombolysis does in the modern era. Notice we're talking about a 60-year-old gal that does not have acute limb ischemia. So we're going to talk about a 60-year-old gal with chronic limb-threatening ischemia with a calcaneal heel ulceration. So she comes in chronically. We see her in clinic. She has a wound. We get her planned for stable presentation to the cath lab. We access contralateral. We shoot her aorta iliacs. They're wide open. We go up and over. Her common femoral's open. Her profunda's open. Her SFA's open. She's got good runoff. We take our pictures down below, and we'll let this run for a second. So, not surprisingly, she's got tibial disease, and someone coming in with a long-standing, non-healing heel ulceration. Her posterior tibial's out, her AT's small, her perineal, as you can see, is filling beautifully, and is the dominant vessel to her foot. And so we go to work. We put a sheath up and over. We're working in the tibials. We put a 6 French sheath up and over. Whenever you're working in occlusive disease, you try to bring that sheath down distal, so the sheath is sitting in the distal SFA. We're able to very easily get across the proximal portion. So we get a wire down across the proximal PT. We can't get down into those medial and lateral plantars. So we say, okay, let's do a little ballooning proximally so we can advance a microcatheter so we can do some work and try and get across the CTO. We do a balloon inflation proximally. And then we're working, we're trying to cross, and then we take another picture. And we might not even honestly have recognized this picture, but as we're seeing it, there's some clot there. And it's like, well, that wasn't there before we started, but it's there now. You know, we're still working in the heel, right? So we're still paying attention to what's going on as we're trying to cross. And then you hear a little ding, and the ACT comes back, and the ACT is 130, and we get our next picture, and all of a sudden that perineal that was open to the foot is now gone. So effectively, we never heparinized a patient. We had a 6 French catheter that was up and over sitting in the distal SFA. We have a leg that's full of clot, and we're super excited about what's supposed to be a foundational basic CLTI case that's now turned into something pretty terrible. So we start working pretty quickly. We've got heparin in, we're still taking pictures, we're still trying to visualize, the patient's having a ton of pain, the perineal's gone, our wire's down in the PT that we never opened anyway. You know, we flip a wire into the perineal as we're thinking and looking for equipment and looking for different sheaths so we can start doing stuff. The patient's now writhing in pain, which she never had before. You know, her calf feels like it's on fire, digital subtraction angiography is becoming impossible. And we're just trying to salvage this. So, you know, welcome to a world where you converted someone who had a heel wound for the last month, and she's now at risk of all the things we've been talking about. You know, below knee amputations, fasciotomies, terribleness. It's getting worse, not better. You know, we've got a wire down, which is nice, and our goal is to try to fix this problem. So thrombectomy has really been revolutionized in the last few years, really. And so we start with this concept of let's see how much of this we can get out right now.
Peter, can you, let's give you a break for a second. Let's see what the panel wants to do.
Yes, that's a great idea.
A good complication. So let's start with Zach. Zach, first of all, do you check ACT before? When do you check ACT? Do you check ACT?
I do.
And when do you check it? Do you check it before starting the wiring, or do you check it as your...
No, I would have done exactly, I think, what you guys did. I would have taken my angiogram, and as I was bringing my sheath up and over and placing, usually I use a multi-purpose guide at this point through a 90 sheath. At that point in time, on that exchange is when I'm giving systemic heparin. I usually shoot, especially when I'm doing tibials, for an ACT in the 250 to 300 like I would for a coronary case, has been my practice.
Anybody doesn't check ACT here? Anybody doesn't check? Okay,
But yeah,
checks ACT.
I do
Great.
check it like that. I give it 10 minutes, and then I will recheck initially.
We have a lot of arguments in our institution. We have some colleagues that don't like to check ACT, so that's why I'm asking you. This is great. Our nurses love ACT. They want to do every 10 minutes. Okay, great. So tell me, what do you want to do here? Zach, what are your thoughts here? So Peter is stuck here a little bit. Unfortunately, there is thrombosis everywhere.
I'd give the heparin arterial while you're getting another IV, unless your nurse has that right away, just so I know I'm starting to work in that regard. And I love that I think my thought process would be the same as yours, to see how much of this I can get out. I mean, you had all that proximal in the distal popliteal. Some of it was going down the AT. I would try to debulk initially. And I'd have a pretty low threshold to give some localized TPA as well.
So what catheter are you going to use, Zach?
I'd use a Cat RX there.
Cat RX.
I'd be a little suspicious. I mean, you did have some disease in that mid-perineal, so obviously you're going to be careful as you're advancing that down there. But I've used a Cat RX pretty much down to the ankle before. It tracks beautifully as long as it's not a heavily calcified diseased vessel. But yeah, you might be touching up that perineal on the back end. But if you get clot and flow, some balloon angioplasty in there is a small price to pay.
Dr. Ramanan, what would you use?
I first would
Rapid fire. We're going to do rapid fire.
Okay, I will give 10 milligrams of TPA first through the sheath.
You will give TPA.
Yeah, into the leg.
Right.
Yeah.
So you give TPA to the sheet and...
Wait for about 15, 20 minutes, let it act, and then I would go with the Cat 6 bolt and suction things out.
So a little bit of TPA followed by mechanical suction.
Yeah, I would do heparin and proceed with the thrombectomy.
Thrombectomy. Anything different?
I'd say you're lucky you have a wire down the perineal, and then I would try to get like a 035 navicross over that and inject around the wire into the perineal, like TPA.
Okay, so the panel is suggesting a little bit of a drug and then a little bit of a suction. What did you do, boss?
Yeah, so we went straight to attempts at thrombectomy, thinking let's see what we can get before we're injecting kind of arterial TPA, though that was certainly on the algorithm. Great thoughts about making sure that you're injecting it directly into a given vessel. You know, anything you inject goes into the thing that's open, and so if you're kind of, here everything's closed, so wherever it goes probably works out for you. But yeah, we dove straight into mechanical thrombectomy, acute kind of exquisite pain, thinking to use some of these new devices. So we actually started with trying to just make sure whatever was sitting at the trifurcation was gone. So we put a 7 French sheath in, we parked a 7 French lightning in, we tried to suck out from above at the level of the popliteal, kind of in P2, seeing what we can get. Didn't improve things, we brought that CAT-RX kind of low profile device all the way down, kind of buried into the perineal, trying to remove as much clot as we possibly could. And so after mechanical thrombectomy, and it's very quick on a slide that we were spending a lot of time, remember when you're using powered aspiration devices, you can park it there. You know, it's continuous aspiration. So you're not just kind of going in and passing and coming back like we used to do with some of the foundational kind of syringe-based things. If you park a CAT-RX or a CAT-7, you leave it for 20 seconds and you just let it continuously engorge clot. It's not losing pressure, it's hooked up to negative aspiration. And so we take some pictures, some improvement, still diffuse thrombus. The PT that we were working in before is still gone. We've got a little bit better flow into the perineal. We actually see some reconstitution of the perineal around a distal clot. The pain's gotten a little better. You know, we end up trying to park a CAT-RX there. We just can't pull whatever's going on in the mid-perineal, and it's still much, much, much worse than it was previously. Do you want to pause?
Peter, a couple of questions quickly. You know, one is that sometimes when we go with the CAT-RX or any of these suction devices, you know, you're getting a reasonable flow. Then you get to the clot, and it's like nothing happening. What do you do at that moment? Do you leave it there? Do you go through slowly, pull back, and then repeat multiple times? What's your technique in regards to trying to get some of these things cleaned out?
Yeah, for aspiration, especially with the engine-based aspiration catheters, I'll park them. So I'll bring them down, I'll park them at the area of the clot, and you just give it time to try to engorge that clot. And the concept is even if it can't pull it out all the way, if it can at least engulf it enough, then you might be able to pull it out of the system. Now, in this situation, our sheath was buried in the SFA, which probably caused part of our problem, but it's actually protective when you're starting to deal with thrombus, because if your sheath is back in the common femoral and you're pulling out lollipopped clot, there's always a risk that that's going to go down into the profunda. So in short, we'll try to park it on the clot. And we do that in the coronary experience now, too. It's something that we talked a lot about as we're thinking about CHEETAH and some of these clinical trials in the interventional cardiology space.
Anybody does it differently, technically, from the standpoint of CAT-6 or anything like that, you know, in regards to how you push down or a similar kind of thought process? Dr. Banerjee. Right. 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 Yeah, I don't park it either, to be honest with you. What I'll do is that I just slowly go through and then come back, and then go all the way through, come back, and then go through again, and then come back and go through again, and then you see gradually that there is some improvement. So that's the way that we have done it, like you guys. Okay, so Peter, now you've done this, you have some improvement. What are you going to do now?
Yeah, so key is that the pain was a little better. You know, so we had a little bit of improvement in pain, and it's also this concept of the fact that this was fresh clot. You know, this was not there before, and so for instance, if this was embolizing, pushing distal thrombus, we might have done something very different. You know, there's some of the new mechanical devices, Pounce, Artix, whatever you're thinking about, that you can try to scrape out stuff that you can't suck out. Here, this is all fresh clot that we're unable to remove. So at this point, we moved into the pharmaco portion of Pharmacomechanical, and we decided to infuse TPA because we had a window to do it. Similar to the last case, we used the ECOS catheter, so we dripped 1 milligram an hour for 6 hours through the interventional sheath. We're going to talk a little bit about dripping TPA and some considerations for it. People ask, how long should you drip? And there's some keys. One, you need to be able to drip in a person not having acute writhing pain. Two, you want to make some considerations about what's happening overnight. You know, if your case is going on at 5 p.m., maybe you're going to drip a little longer and give it time. If you're doing this case like we were at 7 o'clock in the morning, you might want to be taking a look before you're going home for the night and seeing what's brewing. You can always drip longer, but you're also thinking about your total TPA dose and your risk of bleeds. We ended up dripping till the end of the day with a plan to come back at the end of the day. Remember, when you're dripping TPA, you're also infusing heparin, so there was heparin going in through the side arm of the sheath. When you're using an ECOS catheter, you're also infusing coolant, and so I think it's a minimum of 35 cc's per hour into the catheter. We used 50 cc's per hour. Some technical considerations, just to put these out there because I think they're super important. If your sheath is occlusive in the SFA and you're going to drip through that same sheath, pull the sheath back a little bit. This way you actually have blood flow getting down into the SFA around your TPA. Now, if you're doing that, remember that if you're going to still work through that same sheath, you need the running length. So if you put your ECOS catheter or your ultrasound catheter through a pulled back sheath, you're going to need an extra 20 centimeters or something of the pullback. Be aware of the contralateral axis site. I got pulled into a brouhaha once where someone had a contralateral 8 French sheath that was upsized to drip TPA, and that 8 French sheath was occlusive in the left leg. So all of a sudden, trying to fix the right leg boxed the left leg. If the person's having continuous pain and they're writhing and screaming upstairs, you can't just leave them. You got to figure out what you're going to do because that's tissue actively dying. So you need to find this window combining mechanical with pharmacologic where they can tolerate the TPA process, similar to what was going on in the last case as well as in this case. You'll hear about people dripping nitroglycerin and vasodilators through the sidearm of the sheath. There's obviously no data on that, but you can absolutely hook nitro drips up to the up and over sheath and drip that to try and help with distal perfusion, similar to when you're working in a vein graft in a coronary for vasodilatation. Also remember, these aren't end-hole catheters. There used to be a device that was 035 in lumen. You can kind of put it all the way down into a diseased tibial and expect it to drip out. Remember, if you put an occlusive catheter into a vessel, your TPA is only going to drip out the end, and it's not going to get into all that thrombus in the middle. So all kind of important considerations. As the ECOS catheter, it's dripping out of multiple areas. In addition to the infusion of TPA, there's an ultrasound core, which is supposed to speed up the process by which TPA impregnates the thrombus. Last one, if you're dripping long, so if you're dripping 6 hours, you don't have to check too much. If you're dripping for greater than 6 hours, you got to start thinking about checking fibrinogen levels and PTTs and D-dimers, and maybe stopping the TPA if you're starting to see some of these early dangerous changes of TPA infusion. So anyway, we come back to the lab, we take a picture, and everything's back. So the distal heel stuff is still gone, right? And we never opened that. But even our posterior tibial, which we angioplastied, which was fresh, is now back. So there's some pre-post catastrophic thrombosis pictures. Before we did anything to this woman, her perineal was open, her PT was closed. It acutely thrombosed. Mechanical thrombectomy let us get some of the perineal open, but then dripping TPA really helped fix everything. So in conclusion, the last decade has given us a lot of really spectacular mechanical thrombectomy advances, particularly in the arterial space. But there is an absolute role for using either adjunctive or primary TPA like we're seeing in some of these cases, especially in setting of diffuse thrombosis and settings of poor runoff and settings of where there's just clot everywhere. Be aware of technical and clinical considerations when you're doing it, which sheath you're using, where you're parking the sheath. And even if you don't do ALI, you can cause ALI. So you've got to be really comfortable with some of these techniques and tools.
Peter, that was awesome. A couple quick questions related to this. Dr. Tsai, do you check fibrinogen? Do you think it's a good idea?
Yeah, I think you have to have a protocol for checking it if you're lysing, because so usually we check every 4 to 6 hours fibrinogen and PTT. Now the PTT, we only check it to make sure it's not therapeutic. Right? You have 500 units of heparin going through the sheath. You just want to make sure your PTT is not like 60 or 100. But the fibrinogen, yes, we check it, and then if it falls to either 50% of your baseline level, so you have to check the beginning one. This is always the problem, that they won't send an initial baseline fibrinogen. So you have 50% of the initial or lower than 150. People have different cutoffs. Some people have 200. We have 150. If it drops by 50%, we turn it down by 50%. If it drops to 150, we turn it. If the fibrinogen is down to 150, we turn it off. And you have to remember, if you turn off the TPA at the bedside, you have to also consider pulling out the catheter. Usually it's a call to me, but we have definitely had the Lysis catheter occlude without the TPA going through it, which is also a very bad problem.
Spot on with our protocol. If it's longer than 6 hours, we do all those things. If we're planning a 6-hour infusion, we don't, but if it's 6 hours already. You can always drip saline through the TPA catheter, but it'll still oftentimes thrombose.
That's great. Thank you so much, Dr. Peter Monteleone. That was a great case, and we appreciate all the discussion. Okay, I'm going to invite my co-moderator here, Dr. Shirling Tsai, and she's going to talk about thrombosed bypass graft.
All right. Hello, good morning, everyone. 2 short cases so that we stay on time. I have a third one, but we can skip that. That's all right. So these are my disclosures. So this is a case. This is a 78-year-old man who had a right heel wound and great toe gangrene. This guy, we have seen him forever in clinic. Dr. Ramanan, this is Dr. Ramanan's patient, told him for years that he could not have surgery. And then he left, and suddenly he needed surgery. So against my better judgment, I took him for a right common femoral endarterectomy and extensive profundoplasty. I think I might have used 2 patches on this one in order to avoid a very calcified SFA. And he was the nicest guy. He would show up for years, very skinny with his PEG tube. And we told him he couldn't have surgery until I operated on him. Anyway, so he had, so I did a right common femoral endarterectomy, extensive profundoplasty, but he had persistent rest pain and then this wound on his toe that didn't get better. And he has a left BKA on this other side. And he really wanted to keep his right leg. And so these are the pictures after the profundoplasty. You can see here, I actually, this is the common femoral angio. The profundoplasty actually goes out somewhere to here. So it was and I did an endarterectomy of the proximal SFA too. So it took many measures to try to avoid dealing with the distal SFA, which had an occlusion. So actually this SFA is open. There's an occlusion distally with reconstitution of just the AT here, which goes down to the foot. So I thought this was actually quite good and maybe enough to get him out of his rest pain and his foot problem. And his PVRs got better. This is actually pretty good all the way to the calf, but at the ankle and the metatarsal, pretty abysmal still. So I decided to do a bypass, which was also, you have to really think about this one, but he had some vein, but it was short. And so we did it. And the reason I didn't try to recanalize this endo is if you look on his previous pictures, he had a really, really calcified distal SFA and popliteal. I didn't think it would be great to try to get across that, and I didn't think I could stent it. It would be a bad idea to stent it. So he had a short piece of vein. So he did a bypass from the distal SFA to the AT from the medial side. This is actually one of the most painful cases ever. But you can see this got better, right? So his calf PVR is even better than before. It's almost like normal with augmentation of amplitude, and the ankle PVR is better. The metatarsal, there's something as opposed to nothing. So he actually started feeling better after this bypass. His pain got better. He thought his wounds were getting better. We did some surveillance of this bypass, even though I told him he couldn't have any other procedures, but somehow he accidentally got a duplex. And on the surveillance duplex, he had like super high grade velocities at the proximal anastomosis and the distal. And you can even see on the duplex the calcium of his vessels. So this was a problem. We decided to take him back for an angiogram. And on the angiogram, you can see that this bypass is probably almost occluded. And so this is the proximal. This is actually a stenosis of the right above the proximal anastomosis, and then you can't even see this bypass here. So this is the talk is about how to treat occluded bypass grafts. And the 2 cases just demonstrate generally, yes, you can try to thrombectomize them, and usually I thrombectomize them with a CAT RX or some sort of penumbra. In this case, I knew this was a pretty small vein. We were able to, I think this was a pretty recent thrombus, but the nice thing about saphenous vein bypasses, if they go down, you can try to get back into them, and usually, as opposed to a PTFE bypass that goes down, a saphenous vein bypass usually will not take out your outflow. So we got a wire across it all the way into the AT. I did penumbra with a CAT RX and then fixed the proximal anastomosis. I did DCB of the proximal anastomosis, and that looked better. And these are his completion angiogram pictures. It is a pretty small bypass, and this, I saw this, and this, I think, is actually because this was the worst tibial I ever sewed to. It was like a lead pipe. So those of you who think that bypass is the answer to the calcified arteries, this was you have the same problems. If you can't open it with a balloon, you can't stick it with a needle either. It's very difficult. So it is actually just a big problem. But this guy, his bypass is open. He has runoff all the way to the foot. That's his AT coming down. And then, this got better. Even after here's the ankle PVR, it's even better now after we ballooned it and saved the bypass, and he's hanging out with his foot still. So thank goodness. So vein bypasses may occlude because of inflow and outflow stenoses, so that's why you have to do graft surveillance. They can be thrombectomized with the CAT-RX. Usually that's what I use. Sometimes you can get a CAT-6 in there to thrombectomize it. And then if you address the inflow and outflows problems, even on surveillance for asymptomatic people, you can try to avoid the problem of bypass graft occlusion.
Dr. Tsai, let's talk a little bit, a couple of points here, maybe with the panel we can discuss. So we know the problem is inflow and outflow. Have you ever considered putting drug-eluting stents or DCB? You didn't DCB, right? Just angioplasty?
I did DCB of the whole inflow. I did DCB.
You did. And you DCB'd into the bypass or just the inflow?
I DCB'd just the inflow because this was a relatively new bypass. And the outflow, I actually did not DCB, only because I did the operation. I knew that the problem was most likely because it was so calcified in the outflow. I tried actually with a very small balloon, and it recoiled immediately. And I knew that it was a problem because of the really bad tibial outflow.
Okay, how about you, Dr. Varghese?
Yeah, I have done baloney drug-eluting stent multiple times.
At the anastomosis?
Yes.
Yes. And what is your technique? Do you put it, how do you do it? Do you put the whole thing in the bypass? Do you extend into the native?
So I'll try to, it depends on the pathology and how good is the landing zone. Usually go 50-50.
And then if there's a size mismatch, what do you do? Let's say the bypass is 5 and then the PT, let's say it's a bypass to a PT, and the PT is 3. So what's your approach for that?
So if there is a big mismatch, I've actually done supera stents too.
Supera.
Yeah.
So a supera from the native into the graft.
Right.
Okay. Dr. Ramanan, have you considered that? DCB, DES, anything at the anastomosis sites?
Yeah, generally when I have bypass stenosis, I use a cutting balloon and I DCB it. At least for a couple of times. Now, sometimes these are recurrent, and then that's when I would consider stenting, or sometimes we have revised bypasses.
Revised, okay. How about Zach? Anything?
Yes, to both. The other option you can ask yourself is, can you get the native open at that point in time? Because the minute you lay a stent across that bypass, the chance of coming through a wall, or even if you're using an open cell stent, that's going to make that more difficult. Right. This case is not that, obviously. But I think it's important. In our coronary rooms, we have all of our stent charts posted. You gave the example 3 to 5, which I think is a very fair one. There are coronary stents that can adequately be opposed. So if you look at the boxes, those who aren't familiar with all the coronary stents, they'll tell you what the post-dilatation limit is. You can stretch them a little bit further. They just may foreshorten.
Yeah. So the point is that with this, with the drug-eluting stents, you can, increase the size by a couple, 2-3 millimeters even. So you can, inflate with a larger post-dilatation balloon and oppose the proximal to a 5, and then distally leave it at 3. So there is opportunities to do that. And I think for distal anastomosis, they're a very good option. I think the proximal, Zach is totally right, because then you lose your opportunity to open the native. You still can do it, but it can be more challenging, if you jail the rest of the native. Dr. Banerjee, you had a question. Okay, great. Okay,
I think
next
even
case.
with the distal, if you're thinking about stenting across the distal, you are jailing your option to recanalize the native system in that way too. Because if you are trying to use that same tibial to go back,
That's right.
Up.
That's right. You're
So
right.
I think generally when I deal with these, I try to balloon it without leaving something, but invariably they come back, and then it's sort of escalation of ballooning, and then you stent it, and you'll see in the next case I just cover the whole thing. So this is another patient, 68-year-old man. who had a non-healing right TMA after an SFA to below knee popliteal bypass with vein. He was on Xarelto for atrial fibrillation, so we held it for 2 days prior to his surgery, and then his bypass graft occluded in the interim. So here you can see, and he had this popliteal bypass because of an aneurysm, so we couldn't recanalize his native system. So here is his occluded bypass graft. Now, the interesting point about this guy is that he had struggled with this bypass graft many a time before this, so it's not like this is the first time it occluded. We were able to get across it. The outflow looked intact, thankfully, because in vein bypasses, like I said before, your outflow is usually okay, but in PTFE bypasses, when they occlude, it can well take out your outflow. Luckily, his outflow was still good. So we did this one, I did with a Cat 6, I believe, only because I didn't have the lightning at the time. It was thrombectomized it. He had a stenosis at the distal anastomosis here, and this, I'll tell you, was recurrent. It had been balloon angioplasty with DCB at least twice before, which is why after we got it open, I just relined the whole thing with a Viabon and sort of converted this from a vein bypass to a PTFE bypass. So I think that's the other option of managing these occluded vein bypasses, is to thrombectomize it, knowing that if this is multiple times going back, it may be time to just reline it or revise it.
Okay, great. So, relining bypass grafts with Viabon, any comments about that? Zach, any ideas? I know it saved me a few times, when there were no other option. The challenge with the Viabon is that if you're putting it from the native into the bypass, then definitely, for sure, you're not gonna be able to, open up the natives. Yeah. With these other balloon expandable stents, like drug balloon stents, you can cross, and make things happen. Any comments?
You made the point that I was gonna make. I think this is fifth time getting back in there, and so
ultimately with this guy, and the thing is, there was no native system to recanalize in this one, so right. I didn't really mind putting the Viabon right across the top and the bottom because I knew I couldn't get back into the native because it's not continuous. But I think
do you presume you probably had a continuous hyperplasia reaction? Anybody taken a laser and then DCB after in a vein graft? I'd be kind of hesitant myself, but has anybody done that?
Right. So we have done that, but I want to first hear what the panel thinks. What do you think, Dr. Ramanan? Is that safe? Is it not safe? Can you do it? When can you do it?
I've never lasered a bypass graft, not a native vein bypass graft. And as far as stenting, we routinely stent these things, except at the proximal and the distal. I think for the proximal and distal, we have to use something uncovered so that there are other options available.
Any other, I'll talk about the laser. We've done a couple of these. It doesn't go very well. We haven't perforated. I'm going to tell you, we haven't perforated, but the outcome wasn't great. Actually, Tarek, there was a case of mine that I had done laser, and I regretted I did it because we had a good result just doing angioplasty, but we were trying to just, learn and make it better. And when we lasered it, we ended up trashing a little bit the foot, and then we ended up rescuing it. So it worked. Okay. Well, there was no perforation because the concern was that, if you are, lasering, are you going to perforate? So we had no perforation. There was some disturbance because some of these bypasses have a lot of junk in them, and a lot of it is old stuff. And I think that when you disturb them, it may be some embolization and stuff like that happening. How about other forms of atherectomy? Anything? Have you used any form of any other outside of laser, like directional atherectomy in these bypass grafts, Dr. Varghese?
No, I have in bypass grafts. I have not.
Anybody in the audience? Anybody that has used other forms of Dr. Banerjee?
I actually like to disagree on putting a Viabon in this situation.
Okay.
Because there is a size mismatch issue. You don't have good outflow. There is going to be wrinkling of the Viabon. I've actually imaged with ultrasound some of these Viabons, and they don't look opposed to the smaller blood vessel at all. And they actually have wrinkles at the end.
The folding.
Yeah, so I think it may not, this is a last-ditch effort, so it's just right. I just don't want the message to go out that you could put a Viabon and make it look angiographically good, but the price at the back end is very large.
Right. But this patient had a nice PT, that had
He
nice.
had actually, the only reason I consider this is he actually had 3-vessel runoff and, recurrent stenosis at the TP trunk. And also because I knew there was no other salvage of this. Like, we had done this so many times. This was the last time I told him, this is the last time we're going to salvage this bypass graft before you get another bypass. And so if that's, I think the other discussion to have said was, we're not going to salvage this bypass graft anymore. You just need to have a revision. But I think he actually declined another operation. So a lot of this is also patient dependent. Now, there is a case that I'm not going to show out of interest of time where we did have the mismatch with the Viabond relining. It was actually a PTFE bypass graft, relined it with Viabond because it had thrombosed. But that one, we put coronary stents past the distal anastomosis to deal with the size mismatch.
That's great. That's great. No, the other thing I was just going to, kind of mention is that, can you educate us? Because, we always yell at ourselves for keep doing the same thing, like going back doing angioplasty. When you see things like this, what makes you think that revising it is going to make it better? Like, what is it? Do you think is that like the person that did it originally technically did something wrong? Like, how does the revision, is like, for us, like we keep going back doing angioplasty and we get yelled at, and even we yell at ourselves that why did you do the same thing over and over again? So what is it about the revision that corrects the problem?
I don't think it's not a complete fix, but it is an alternative to what you're doing. The problem, so it depends on what the problem is and when the problem occurs. So usually bypasses fail at 3 different time points. So if it's immediate failure, it's a technical issue.
Yes.
If it is after, between up to 2 years, then it's probably intimal hyperplasia. And beyond that, it's usually recurrence of atherosclerosis.
Yes.
So if it's a bypass that's been there for a long time, and they are getting recurrent stenosis in some area, that's probably atherosclerosis, and doing a redo or a revision there probably will help. Intimal hyperplasia, unfortunately, nobody has found a good solution to that, and it might occur again, even with a new revision. So it's a better solution than doing the same thing again and again.
Right.
Would anybody consider DCB and Supera in this case? Just curious.
I think you could do that. The reason I relined it is mostly because it had thrombosed before, and I always feel like there is a residual thrombus. The Supera, I think, may have been reasonable at the distal anastomosis, mostly because, the size might have been better. This, luckily, was actually a pretty good-sized bypass graft, but the problem was the TP trunk at the outflow, so that might have been a better, size thing.
All right, great. Well, thank you very much, Dr. Tsai. That was wonderful. Thank you for sharing those nice cases. We're going to hand it now to Dr. Bashir, who's going to talk to us about the balloon pulmonary angioplasty for CTEPH. And we have had a lot of discussion in this meeting around PE and acute PE and so on and so forth. So thank you so much.
Thank you very much, Dr. Shishehbor, and thank you, Subhash, for the invitation. I'm going to give you a little bit of a break from limbs, and we'll go to the pulmonary circulation and talk about things that are not acute clots. I know acute clots are stressful for interventionalists. I do have some disclosures, and they're not relevant to this talk. Chronic thromboembolic pulmonary hypertension is defined as a mean pulmonary artery pressure of greater than 20 millimeters of mercury, with a wedge pressure of less than 15, 3 months after anticoagulation for acute PE. And the incidence of it is around 2 to 3% in all-comer PE patients. There is a much more common disease that makes people short of breath after PE, and that's chronic thromboembolic pulmonary disease. We also call it CTED. Those patients have mean PA pressure of less than 20, but it increases dramatically when they exercise. And they have significant dead space ventilation. And the incidence of CTED ranges from 7 to 16%. I'm not sure why it's moving on its own, but these are the pictures of what happens inside these vessels and how these thrombi get recanalized. Now, the first line therapy for these patients is pulmonary thromboendarterectomy. And you can understand why thromboendarterectomy is potentially curative in these patients. The problem is more than half of these patients actually don't get surgery. The reason they don't get surgery is probably because the disease is way distal and the surgeon cannot reach them, or patients have too many comorbidities, or they refuse surgery. There is a growing population of CTEPH patients that need balloon pulmonary angioplasty, and that's ones that have already had surgery and still have significant residual hypertension and symptoms. So it's in these patients where the ESC in 2022 gave a class 1 recommendation for balloon pulmonary angioplasty in these patients. So it's the first line therapy in these patients with CTEPH. So here is a case of a 47-year-old self-employed painter. He had a splenectomy. In splenectomy patients, they get very distal disease. So this is a very different phenotype of thrombosis. And you can see his proximal pulmonary arteries are normal, but there is a cutoff of multiple distal segments. And when we do selective angiograms on them, you can see there are multiple distal lesions and webs in them. And those are the ones that are making him very symptomatic. He was so symptomatic that he had to stop his business. And these people have different types of lesions than atherosclerotic type of lesions. There can be webs in them, there can be pouches in them, or luminal irregularities, or sudden tapering or total occlusions. And many times you will miss the lesion unless you have some sort of hemodynamic assessment in it. So the way we do balloon pulmonary angioplasty is we put a 9 French sheath, usually in a femoral vein, and take a 7 French long, 70 centimeter sheath into the pulmonary artery, and then use a guiding catheter. Most often we use a JR4 or an AL1 for the left, JR4 for the right. And I personally use a RadiWire supported with an over-the-wire balloon to cross these lesions, which is successful in 60% of the times, but other times I need a BMW or a run-through wire, and rarely would use a hydrophilic wire. And I would perform the balloon angioplasty over a RadiWire just to know what's happening distal to the dilatation. So you can see there is a very tight lesion here, and when the wire crosses that lesion, it turns into a wedge tracing. And you pull the transducer back into the lesion, it ventricularizes. So it exactly identifies for you the location of the lesion, and you can dilate it. But what you want to do is you want to dilate it with an undersized balloon. You don't want that distal pressure to suddenly increase to 80 millimeters of mercury. That's what causes reperfusion edema and pulmonary hemorrhage. So you want to undersize your balloon the first time and then get the patient back for an optimized ballooning. So they won't look much different after ballooning. The vessels look literally many times the same. But you will have brisk venous return. And that's what you're looking for, is a brisk venous return. And you can see these vessels grow over time. So when you have opened up a total occlusion, they'll keep getting bigger and bigger as time goes by. And you will see improved perfusion, just like this patient. And this is his VQ scan. You can see the difference on the right lung from before and after. And his 6-minute walk distance increased from 360 to 440, and his PVR dropped from 6.8 to 4. And he started his business again. So it is a really massive improvement in the quality of life of these patients. Here are a few more examples. This is an example of restoring perfusion. Here is a total occlusion that we opened, and a month later, the vessel is much bigger than it was right after opening it up. Here's another total occlusion on the left side here. And new vessels are born as we dilate these vessels because we don't know how many vessels are occluded. Here's an interlobar occlusion. That patient was not a surgical candidate, and we were able to revascularize. So So this is the examples of cases that we do. Now, how is the evidence for this, that what led to class 1 recommendation? So that's where the real issue is. So the total number of cases reported in literature based on observational data is less than 5,000. And 1/3 of all these 5,000 patients have come from Japan. And there are 2 randomized trials with a total of 166 patients that have compared angioplasty versus riociguat. That's the totality of data. The good news is that all the observational data is very consistent. There has been marked improvement in PVR, marked improvement in PA pressures, and in biomarkers. And the 6-minute walk distance has increased consistently in all these trials. And so has NYHA class, functional class. And this is comparing the outcomes of these patients against historical controls, and the survival is significantly better. Now, this is hot off the press, just got published a month ago in JACC. This is International Balloon Pulmonary Angioplasty Registry in 18 centers throughout the world, and 4 of them were in US. And it basically showed there was 0 in-hospital mortality in these patients and 11% BPA complication rates. And the bottom line from this registry was that more experienced the centers have, better the outcomes. More vessels we treat, better the outcomes. And higher the baseline pressure, greater the reduction in the pressure. Now, the Achilles heel of this space has been complications. And the complication is bleeding into the lung, or pulmonary hemorrhage, and reperfusion pulmonary edema. But the good news is that there is a significant learning curve associated with these complications. So more experience we get with doing them, the complication rates are significantly lower. And this is our own experience. You know, we have done 500 balloon pulmonary angioplasties in 168 patients, and almost 1/5 of these are post-PTE patients. And we published our 211 session series in JACC a year or 2 ago, and it showed that PVR reduction was significant, biomarker improvement was significant, and so was the 6-minute walk distance. And our hemoptysis rate was 4.2%. Now, what we noticed in these patients is that there is a serial improvement in their quality of life. And this was the most dramatic thing we see in these patients. So then we wanted to see, how do we use this quality of life as an endpoint for a clinical trial? We didn't have very good quality of life instruments in patients with CTEPH. So we validated KCCQ against a disease-specific quality of life instrument called Emphasis 10 and found that this correlated very well. Because CTEPH patients get right heart failure and that leads to symptoms. So we know TriClip got approved based on KCCQ. So good news was that it correlated very, very well with Emphasis 10. And then we wanted to see, is it responsive to therapy? And we noted that there was a 14-point increase in KCCQ summary score just with 1 session of balloon pulmonary angioplasty. Now, this is all observational data. What about the randomized trial? This was a 105-patient French trial called the RACE trial. Showed that there was a significantly better improvement in PVR with balloon pulmonary angioplasty compared to medical therapy. They had 8% complication rates. And Mr. BPA trial from Japan enrolled 61 patients. It was randomizing BPA to riociguat. And again, there was a significant improvement in mean PA pressure compared to riociguat. Now, what is the limitation of these randomized controlled trials is that their primary endpoints were hemodynamic, not clinical. And the blinder and the assessors were not blinded. And there was no multimodality therapy. And therefore, these results are not generalizable to US population. And so what we wanted to do is we wanted to do this randomized trial in United States where we would compare balloon pulmonary angioplasty with medical therapy versus medical therapy alone, with an option of crossover at 6 months. So in conclusion, in 2025, at CTEPH Centers of Excellence, that's a very important point here. The PT is first-line therapy because it's potentially curative. And BPA is a reasonable option in patients who are inoperable or at high surgical risk. And we really need a randomized trial in US to show the efficacy in United States. I want to thank Dr. Matsubara and Dr. Bill O'Jay for teaching me this space. I really couldn't do it without them. Thank you very much for your attention.
Thank you so much, Dr. Bashir. I think, this is, you did an amazing job of kind of presenting the complexities of this condition. I think this is one, tell me if you agree with me, but I think this is one procedure that you really need to have a program. And I think at the end you emphasize that. You really need to have a program, a surgical program, a pulmonary program, and a CTEPH program. And you're just, the interventional is just one small component of this team. And these cases have to be discussed in a multidisciplinary setting, and then decisions made in regards to what's the right approach. And sometimes the approach may be hybrid, maybe a surgical approach. The surgical technique for this is also not that straightforward to be able to get really to the distal branches, the secondary and tertiary branches. So, thank you. Thank you for, I think this is the future, but I think it requires really a multidisciplinary team. Would you agree?
I totally agree. I actually wanted to bring up this one point. I have a couple of slides talking about that this is a multimodal therapy. These patients need multiple modalities. And the first step in the algorithm of treating these patients is a multidisciplinary team. So if you don't have a multidisciplinary team, you cannot get into this algorithm. Since surgery is the first-line therapy, the surgeon has to say he cannot operate this patient. So that's why it's really critical. And the other thing is to understand which anatomy needs surgery, which anatomy needs balloon pulmonary angioplasty. So farther out you get, you're better candidates for ballooning. More proximal you are, you're better candidates for surgery. And finally, we all need to familiarize ourselves with the anatomy of pulmonary vasculature, which is fairly complex compared to coronaries, which is one of the challenges in doing this procedure.
Great, thank you so much, Dr. Bashir. Really, I learn every time I hear you talking, so it's just amazing. Thank you. So I'm going to invite our last speaker, Dr. Bala Ramanan, who is going to talk to us about surgical embolectomy.
Thank you for staying till the end, and thank you for the opportunity to present. I have no disclosures. I actually have 4 cases, but I might just go to the second and fourth case for time. Okay, so my first patient is a 69-year-old male with a 2-day history of left foot pain and dusky toes. He was initially admitted for a heparin drip with plan for thrombolysis or thrombectomy the next morning. However, he subsequently lost motor function in his left foot. That's his history. So on exam, his left foot had decreased sensation. And initially, he had movement in the foot, but during the hospital stay, he lost movement at his ankles and toes, and he had pretty significant calf tenderness. So I can just stop here and ask the panel what they would do at this point. So this is like 2 in the morning, and I got called that he's lost motor function.
And do you know the anatomy of his PAD? But I assume you had already known if he had been admitted.
Yeah, so at admission, he had the CT scan. So he had a common iliac stenosis, and then pop goes out, and it looks like he had maybe one vessel runoff.
Yeah, I would go for a peripheral angiogram. I would like to see the invasive angiogram first.
Okay, so I'm talking about surgical embolectomy. So I will say my approach was different. And I would say most of the ALI cases, we do an angiogram. However, there are some situations where I will start first with a fasciotomy, and this was the case. And the reason I started with a fasciotomy here was because I did not know if his muscles were already dead. He had no movement at his ankle. Like, he was moving initially, and he had no movement at his ankle and his toes. And if the muscles were already dead, I was not going to do anything. I was not going to be able to do anything to revascularize him and save his leg. So these were my options: endovascular first, open first, or fasciotomy. And if this was even needed, in this case, I started with the fasciotomy. So I did a 4-compartment fasciotomy first, and then looked at all the muscles. The muscles were pale, but they were not frankly dead. And so then, because I had already done the fasciotomy, I just proceeded with an open thrombectomy. I think if this patient had not had the severe change in his exam, we would have done exactly what we normally do, which is start with an angiogram, take pictures, try to do something endo, and see if we can salvage the foot. And then after the thrombectomy, I also stented the left common iliac with a VBX stent. This was his ABI after surgery. And then the saga was not over. So I think the reason he lost motor function is because the blood supply to his gastrocnemius probably was compromised. And so he had progressive necrosis of his gastrocnemius as well as the skin, as well as his lateral fasciotomy. And this is, when I saw this muscle necrosis, I was uncertain how extensive it was. So we got a CT scan, and this is probably one of the most impressive CT scans I've seen for gas in soft tissue. So our repair was open, the blood flow looked good, popliteal was good, but you can see there severe gas in the entire medial head of the gastrocnemius, which we ended up having to take out the whole medial head of the gastrocnemius. We debrided multiple times, going back to the OR, debriding, and ultimately he granulated and got a skin graft. So the key points that I wanted to bring up in this case was severity of ischemia determines the urgency of the operation. So initially he was possibly just a 2A ischemia, and then he converted to maybe even a 3 ischemia, and that's why we had to immediately take him to the OR. Fasciotomy was performed first in this particular case to assess the viability of the muscles. And the underlying culprit lesion, which I thought was the common iliac artery stenosis, should be treated if it's possible. And then we do need to follow up these fasciotomies long-term till they completely heal to make sure that the muscle remains viable, and they may need further procedures to aid with healing or even may need amputations.
Dr. Ramanan, can I ask a couple of questions here, maybe from you and the panel? From the surgical embolectomy standpoint, is it a standard that these are done in collaboration with angiography, meaning that is that a standard kind of practice?
I think in this day and age, even if you do an open embolectomy, unless you have a palpable pulse in the foot, you should always do an angiogram. And it is pretty rare, in my experience, to get a palpable pulse in the foot right away at the end of a case, because sometimes they have underlying lesions, that need to be treated, and you may not even know what the lesion is when everything is thrombosed. So the thrombectomy is the first step, and then I think you need an angiogram in almost all cases.
Second question I had is that when you do this fasciotomy, I think this was a great case and obviously made a lot of sense, your approach. Is there any concern if you decided that, because of distal embolization or other reasons, that the embolectomy was not effective enough and you need to do lysis? Is there any concern when you have done the 4-compartment fasciotomy with lysis?
Yeah, in general, you don't want to do lysis in anyone who has open incisions because the bleeding cannot be controlled. I have, in these situations, not put a lysis catheter in. I generally just inject TPA into the vessels. So, we have an open incision in the artery. I'll put a catheter or something in there, and then I'll just inject TPA down the vessels. And generally, the limit with surgery is we can get everything open till the foot. We cannot get the foot vessels open, like into the pedal arch. So we can even cut down at the foot and do thrombectomies, but we cannot go into the pedal arch. And so if there is concern in that area, then generally you do have to inject TPA into the foot. But I would not leave a Lysis catheter and drip them because you cannot control the bleeding.
And we know TPA has a short half-life. The last question I had was related to the actual the fasciotomy. Technically, you showed it was a very long, just we have some surgeons also in the room. How important is the length of the fasciotomy? Because I've seen sometimes folks have done like limited fasciotomy, and I don't know, and later on I learned that, actually that's not maybe that's why we lost that patient's leg. Maybe we should have done full fasciotomy. Can you teach us, when you do a fasciotomy, what's the proper fasciotomy?
So routinely I do these full-length fasciotomies.
The pointer, by the way, the last button on the thing is the pointer.
Oh, okay. So I do the entire length.
Maybe you want to point it here.
Oh, sorry. Entire length of the leg. That's the lateral incision, and this is the medial incision. This medial incision actually helps to relieve the superficial and deep posterior compartments of the leg, and the lateral incision relieves the anterior and lateral compartment of the leg. Okay, there are people who do limited incisions, but those incisions are only useful if you are trying to do a prophylactic fasciotomy. So patient has not developed compartment syndrome. There is no concern for any dead muscle at the current time, but you're doing the fasciotomy in order to prevent the appearance of compartment syndrome. In that case, some people do a limited fasciotomy. I never do that because this is also a very highly litigious problem in our field. If you do a limited fasciotomy and the patient then subsequently loses their leg, that is a highly litigious problem.
Even with the small incisions, you're supposed to open the fascia underneath the skin. So then that's a blind movement of the scissor, which works in some cases. But you can get into all sorts of bleeding especially on the medial side with the saphenous vein. How many times have we run the scissor right through the saphenous vein trying to keep a small skin incision? It happens. But the thing is, if you do that, even though you've released the fascia, you can still have a compartment syndrome from the skin if you haven't opened the skin all the way. It's just something to keep in mind. I haven't successfully measured a pressure.
So measurement of pressure is only in order to not avoid doing a fasciotomy, in my mind. But if you suspect a compartment syndrome, you just have to do it because the chance of limb loss is so high if the patient has a missed compartment syndrome. Having a couple of incisions and having a wound vac for a couple of months is better than losing the leg from a compartment syndrome.
If the suspicion is low, I usually do it and then I leave the sutures in to tie it down later. Makes for annoying wound care for a couple of days, but if they truly didn't have a compartment syndrome, the skin will come together in a day or two and you can close it at the bedside.
But the other learning point is that the closure has to be really early. So it only closes within the first 3 to 5 days. Usually within the first 2 to 3 days. If you can't close the wound by that time, that incision will not close. So either the patient is going to develop a compartment syndrome and have an open incision, or they are going to avoid the compartment syndrome and just get their leg closed. So they'll just have long incisions, but they will not have an open wound like this.
I have a question to all the doctors who treat the ALI. What is the timing of ALI treatment? For example, if you get an 11 p.m. consult, do you wait till the morning or do you just immediately come and take care of the patient?
So ALI, in my mind, it depends on the presentation of the patient. I'm trying to find the slide. Basically, it depends on the Rutherford stage when they present. The severity of the ischemia determines the urgency of the operation. So if the patient is coming in with just rest pain or they have just sensory loss, which is Rutherford 1 or 2A, then you can wait and do the operation the next day, whatever the procedure is. However, if the patient starts getting motor loss, which becomes Rutherford 2B, at that stage, that becomes an emergency. And then once they get complete loss of function of the leg, which This patient had loss of ankle function. That's why I tried to save the leg. If they lose function all the way to the knee, then it becomes a non-salvageable leg. And at that point, they just need an amputation. But the real differentiation between whether you can wait for acute limb ischemia or you have to treat emergently is the loss of motor function. Okay, I am going to go on to my last case. So this patient presented with a fall and was unable to move the leg. So this was a 60-year-old male who had pretty significant medical history. So he was on AFib for anticoagulation. He was a current smoker, and he had HCC and had had RFA ablation of his liver tumor by IR about 5 days prior. And for that procedure, they held his anticoagulation and never restarted it. So this patient, when he came, was paraplegic. He had bilateral cold legs up to the groins. He was pale. He had no pulses or signals in his legs. And this was his CT scan. So obviously an aortoiliac occlusion. The rest of his runoff was open. And this is the 3D reconstruction of the aorta. So what would you guys do in this stage?
Call you. I mean, you got to prevent distal embolization here. You've got good runoff, as you pointed out, without significant disease. I mean, this is something that if you don't have a vascular surgeon here, you need to make sure you're not going to make your problem worse as you go to evacuate this. So, like in my case example, when we upsized to a 12 French sheath, we felt more comfortable about preventing from distal embolization.
Yeah, so that was exactly the point I wanted to bring up with this specific case is sometimes, you can maybe try to do this with a penumbra or some other suction thrombectomy, but distal embolization is a big problem here. He's already embolized his pelvis and probably his spine, and that's why he's paraplegic. So we need to try to prevent more embolization. So we did bilateral femoral cut downs. So these are the options again. So we did bilateral femoral cut downs. We did open thrombectomy of the aorta via groin incisions. So the other options for doing an surgery here, so we could do endo and do suction thrombectomy. We can do bilateral open cut downs, do thrombectomy through the groins, or we can actually do an open abdomen approach, open the aorta, and do a direct thrombectomy of the aorta, which is obviously more invasive, and we try to avoid that. Also, we did 4-compartment fasciotomy. Since he was already paralyzed, we didn't know if he was paralyzed because of spinal cord ischemia from the aorta or he was paralyzed because of the leg ischemia. But we did the fasciotomies. And then he continued to be paraplegic. He eventually developed colon ischemia and then ended up with a colectomy. And then ultimately, after a long hospital stay, was discharged to rehab. So acute aortic occlusions are associated with a very high morbidity and mortality. 30-day mortality can be up to 52% in the literature. And it's even worse if you have colon or spinal cord ischemia. And then colon ischemia, again, is usually due to embolism. And these patients have a very high rate of amputation. Thank you very much for your time.
Thank you so much. I think this was a great session. We learned a lot from each other. And